Have you ever wondered what's in our blood? What it can tell about our well-being? What about the innovative technology used to unravel the mystery of what's in our blood? Hello, I'm Dean Whiting, and this is It's in Our Blood, the podcast series that explores the critical role technology plays in the pathology laboratory, in hospitals, and in the community setting. And today we're going to be talking about the accessibility side of pathology testing and the technology that is required to make this happen. To help us today, we've got Mr. Mark Volling, Regional Managing Director at Abbott Rapid Diagnostics. So hello, Mark, and thanks for joining us.
Hello, Dean, and thank you very much for the opportunity.
Very good. So, something that you might not know about me is that, in my days in the past, I did a stint where I was training nurses who were taking, in the delivery suite, who were taking very precious scalp blood samples from babies who were still in the birthing canal, and then using technology to determine if those, how the babies were traveling, whether they were under stress. And that's a really good example to me of how point of care technology can be really helpful where you need it most, where you need to act rapidly on an outcome to affect a good healthcare outcome. So I guess, from your perspective, how would you define point of care testing?
I define it as testing that's occurred anywhere beside the patient. Now, whether that's, doctor's surgery, in community testing, in a hospital department, it's fairly general. And, it's even in workplace testing, like there's a lot of toxicology testing that goes on in the workplace to see fitness for purpose for the fitness for work for the workers, etc. So there's point of care testing in a lot of different places that people don't take into consideration, and you could even put into that bucket home testing, for blood glucose or INR, for example.
Yes, there's all of those, and at one stage I was also working with a group that was performing some diabetes testing in remote and regional centres for Aboriginal healthcare services, and that was, I think, a really good example of where you've got you're far from a conventional medical support system. You have you have quite difficult environment in which to work. Yet being able to do the diabetes testing in the remote indigenous communities made a really huge difference. So I think that's another example. I wonder, Mark, how have you noticed, the technology changing since, the days way back when I was teaching nurses how to measure pH on scalp baby samples?
And Dean, they're still probably doing that today.
Oh, is that right?
because because the technology, there's still a clinical need for that sort of testing. But wow, how technology has changed since then. As with technology advancement generally, point of care in vitro diagnostic testing continues to innovate. I'll give you an example. Take historical molecular technologies, for diagnosis of infectious diseases. Used to take half a day to days for a result that's generated by the lab, and that's once the lab gets the sample. But today, we're able to do a molecular influenza result within 15 minutes. And that's beside the patient. It could be in the ED, it could be in a community setting somewhere, like aged care facility, for example. And then and there, the attending physician or nurse is then able to make a definitive call immediately on the next management steps with that patient. And Dean, the great story today is that current technologies are now providing solutions to the historical concerns of accuracy of results. Maintaining instrument calibration, the quality control, and the surety of patient result identification. But, unfortunately, as you will be aware, duly embracing the technological advancements in point of care near patient testing must become a greater priority for our health system.
Very much, Mark, very much. And I guess, the extension of that is the benefit to the medical professional and the patient outcome. Tell me a little bit about what you see as the big benefit of point of care testing from the medical professional perspective and for the patient outcome.
Dean, it's funny, I sort of touched on it just before, but I think people forget that over the past 20 odd years, point of care IVD testing, for many of us has become part of our daily lives. A person living with diabetes thinks nothing of doing their routine blood glucose testing. That is point of care IVD testing. And then you've got the hopeful mother who's purchasing and using both an over-the-counter ovulation detection and then a pregnancy test. That is point of care IVD testing. Then you've got the patient on long-term warfarin therapy undertaking fingerstick INR tests in the home. That is point of care IVD testing.
Yeah.
And then at the doctor's surgery, just doing a simple dipstick urine. That is point of care IVD testing. These are accepted and trusted IVD point of care technologies that provide the clinical value and convenience, to both the patient and the treating clinicians. And we're seeing these technologies increasingly being used in remote and rural locations, by clinicians and local community health groups.
Yeah.
And that is despite the lack of specific reimbursement and or other funding, as you know.
Yes.
It'll be interesting within the next 10 years, though, when there will be even more efficient, smaller benchtop technologies enabling cost-effective and accurate performance of tests in GP clinics covering, routine tests such as full blood counts and electrolytes, liver functions. And, Dean, personally, I see this as a great opportunity for laboratory networks, whether they're public or private, to innovate their current operational business models. The laboratories need to take a lead with government, the medical colleges and the general community to physically take relevant pathology testing, outside those cloistered walls of the laboratory to a place where it has the greatest impact and, that is beside the patient. Now, that's not all testing, but there is certain tests that is just, it's so applicable that it needs to be done.
Yeah, no, I think the message is very clear. And look, I'm just going to forward promote a podcast coming up about influenza, and we're going to be talking about the technological advances which allow us to do a rapid flu test beside the patient, and that could be so important to initiate the antiviral therapy or to initiate the appropriate therapy to deal with what could be a very serious flu infection, deal with that immediately and on the spot. This podcast is brought to you by Pathology Technology Australia, the peak body representing the companies who invent, manufacture, supply and support the vital technology needed for testing those precious patient samples. Did you know that pathology tests provide vital information for about 70% of medical diagnosis and 100% of cancer diagnosis? Pathology Technology Australia, representing the companies who provide the innovative technology so critical to a high quality, affordable and accessible healthcare system. But just coming back to your point, I guess, around how we get point of care testing more better funded, more adopted. I often hear that point of care testing is more expensive than the same test done in the lab, and that may be a barrier to adoption. What do you say about that?
That hoary old chestnut.
Yes.
Cost per test of point of care versus laboratory test. Well, Dean, you know as well as I do that when you compare to big box analyzers sitting in large centralized laboratories, when you look at it on a straight cost per test basis, it's in most circumstances more expensive to do point of care tests. However, there are tests today that can be performed accurately beside, with, or by the patient, where the patient, the clinician, and the health system receive not only the benefit of a fast and accurate result, but other indirect benefits also. So I'll give you a couple of examples, simple benefits here. The patient doesn't have to spend time, travel costs seeking out a pathology collection centre. For the clinician, they can make more decisive clinical decisions immediately. For the health system, there is not the additional expense of funding the patient for a return visit to the clinician to discuss the results. And then also we are now seeing many new clinical diagnostic algorithms being supported by point-of-care IVD testing. I think then you're aware of the use of those CRP testing at the point of care. That's a classic example. But the NICE clinical guidelines in the UK use point-of-care CRP in the clinical workup of a patient with lower respiratory tract infection. The point of care CRP result helps the clinician discern whether or not it is viral or bacterial infection, and therefore whether or not the clinician should prescribe antibiotics. Now, the use of the CRP test at the point of care for this patient group is a win all round for the health system, and this is very important. For the patient, no unnecessary antibiotics and related costs, financial or health-wise. A win for the clinician as they are appropriately prescribing antibiotics or not. A win for government as the subsidisation costs of an antibiotic to government are reduced. And a win for the general community, which benefits from an incremental reduction in risk of further antibiotic resistance developing. So, I can't think of a better example of a win-win all around because of point-of-care testing.
Well, that's a very compelling argument. But I mean, to counter that, I'm very much aware that there are concerns that a clinician may perform a point-of-care test, or it may be performed near the patient, and then the doctor ends up sending the same sample to the lab anyway, which might have obvious cost implications. Is this a concern or not?
It can, it may be justified for a clinician to send a second sample to the lab if there's some underlying clinical condition in the patient that they're not sure of. But in the main, retesting is very much an attending physician confidence issue, I think. And it relates to some point-of-care testing, not all. However, as point-of-care technology advances generally, we'll see greater clinical confidence coming through here. And for the point-of-care tests routinely performed, this will become an even lesser issue. Also, we look at the cost today of point-of-care testing is not a general concern for the government because there is no cost implication currently. There is no current Medicare reimbursement for point-of-care IVD testing in the professional environment. Professional point-of-care IVD testing when performed is basically a user pay system or via federal and or state specifically funded programs. And a couple of these program examples for you, Dean, is the QAMS program for point-of-care diabetes screening management with Indigenous populations, which you mentioned earlier. And another would be the federally funded program for point-of-care syphilis testing, currently underway across Australia in remote rural Indigenous populations. And an interesting point here on the diabetes point-of-care community testing is that there is no direct federal government funding for point-of-care diabetes testing within the general non-Indigenous population, even where data from the Australian Institute of Health and Welfare shows that the rates of developing diabetes in lower socioeconomic metropolitan and regional populations communities is also very significant. That is a prevalence of approximately 7% in the lower socioeconomic group versus a prevalence of approximately 4% in the highest socioeconomic groups. And that's in the non-Indigenous population. That is really a 50% difference, which is hugely significant.
Yes. So look, I mean that message couldn't be clearer. Yeah, that message couldn't be clearer. Are you there, Mark?
Yep. Sorry, I thought it dropped out.
No. Okay, fine.
So start from what you just said.
Yeah. Yes. So, Mark, the message couldn't be clearer, really. And I'm glad you gave the example of diabetes, and that also brings up the topic of the quality of point of care. And you and I now mentioned the Aboriginal Medical Services hemoglobin A1C, but when I was involved with that many years ago, the quality of that service was outstanding. It was at least equal to a laboratory service. And so from my understanding, the quality of the results can be, just about as good as a city lab. Are there quality concerns today, and how does the technology help us alleviate these?
Yeah, there's always a concern for any technology, whether laboratory-based or point of care. However, every day new technologies become available to enable point of care testing that are easier to use, that generate laboratory quality results, are faster, and importantly, at ever diminishing costs. In fact, there are many point of care instruments developed by PTA member companies in use today that are analogous to a laboratory in the box. PTA member companies have point of care instruments that undertake self-calibration on a per test basis, schedule the running of routine QC material, can communicate to laboratory information systems, hospital information systems, practice management systems, and patient electronic health systems. And with today's ICT technologies, the instrumentation may even be directly managed and or controlled remotely across a wide geographical diverse network. And, you know, then it's this remote management capability that I see as a huge opportunity for both the public and the private labs to manage testing out into the community. And, you know, there should be a funding model to duly incentivize and support this capability. Hey, but don't get me wrong. Unfortunately, there are point-of-care IVD devices, systems, technologies out there that are not of a quality to ensure the accurate, reproducible, cost-effective, and valid test results, you know, we all demand. And again, here, you know, point-of-care technology system validation by competent and credible laboratories can assist in negating this concern. And, you know, that's where I see the laboratories playing an even greater role. So then if I suppose to summarize for you and the listeners here, the challenge as I see it is to ensure that as the value of accurate and trusted near patient point of care testing is increasingly appreciated by all stakeholders, you know, by stakeholders, I mean patients, clinicians, community, government, the medical colleges, you know, that government play their part and duly consider funding greater point of care near patient community testing accordingly. And I hope that occurs in my lifetime, by the way.
Well, you're a young man, Mark, so there's plenty of scope for that.
All relative, Dean.
Look, look, you've made some wonderful points today, and I think that's really helped illuminate a lot of the topics around point of care and the importance that it plays in offering a high quality, affordable, and accessible healthcare system in Australia. So it just remains for me to thank you for joining us. And thank you for sharing your insights. And that's it for this podcast. So thanks very much, Mark, and goodbye to everybody now.
Thank you, Dean, and thank you everyone for listening.
Thank you for listening to this edition of It's in Our Blood. Look out for further topics in this series or go to pathologytechnology.org.au. This podcast is produced by London Agency, Melbourne, Australia.